immunology or cancer immunology, as you would have imagined, is an important thing. So good news and bad news. Bad news as it stands is that 1 in 3 of us will develop some form of cancer during our lifetime. So that's a very bad news, honestly. And if you look at statistics that we have for cancer, you can see from here 8.2 million people die of it each year. Okay, and they think that this are going to be doubled by 2013. So it's a lot of people, a lot of deaths, and you know, your family, greater family, smaller family, it's out there. So what is it that we're going to do for it? The good news, I don't know how far that is good because I don't see the good results in immunology exams. The cancer immunology is there for the help of those people, and you will see a big boost in research, in jobs, whatever you want to call it, but it remains as the most important. And as a matter of fact, if you were ever to look at statistics, cancer immunotherapy is #1 global scientific project. So if you are looking for a job prospect or research prospect or anywhere else, this is your field. So unfortunate that I'm just going to touch upon it for 1 hour, just to give you a basic idea. Hopefully, some other people may take it eventually in your subsequent years. So as I said earlier, if you look at the Global Innovation Survey, something which is coming up, so you can see target chemotherapy 4%, hormonal therapy 8%, gene therapy is picking up, but by far 38% is immunotherapy. So you need to know all these terms that we've been talking about so far, and all these concepts, if you ever want to go in that direction in terms of immunotherapy. How many of you heard of that? Well, there are a lot of movies and so forth, but when immunologists talk of kiss of death, so they pretty much talk of this figure over here is from your book, a very well-known figure. And what you see is there's a macrophage and is kissing a melanoma cancer cell. And that is considered as kiss of death. And that's basically one of the hallmark of immune therapy. So these cells, in this case, the macrophage, it could be any immune cells, are there to help us fight our case when we have to talk of cancer cell, in this case, melanoma cell. And why the reason is why we say kiss of death, because most of the immune cells want to kind of touch with, with the cancer cells. It's more of a physical kind of a contact that we have in terms of therapy. Now, today I will talk about a little bit repeat of what we've been talking about so far, try to put things together. What are the cellular and molecular mechanisms? And you just have to jog your memory. Then I'll also talk about what is the relationship that we have between a host and the tumor, and pretty much the same as self versus non-self. Nothing new for you. And we'll also talk about some of the approaches that we have in terms of diagnosis of cancer, prophylaxis and therapy per se. If you do remember a little bit of pathophysiology that we discussed in physiology, last 10 lectures of physiology, those of you who want to jog their memory, there was one good lecture on that, if you remember that. And there were quite a few figures. I just picked up some of the things that, why is it that we are worried about cancer, and what is going on in cancer that you want to stop that. So you want to stop their activity. They stimulate their own growth. They ignore growth inhibitory signals that we have. They avoid death by apoptosis, so they're very clever. They develop a blood supply angiogenesis. When we talk about the angiogenesis, we talk of VEGF and other those factors at that time. They leave their site of origin to invade metastases, other tissues. So by the time even you would not notice a small melanoma at the back of on your back, on skin of the back, it would have already spread out to liver, spleen, brain, and wherever. So that's the tough bargain we have. They replicate continuously and expand their numbers, like what you want to do in terms of T and B cell and antibody. The problem that we're going to discuss today, especially in this lecture, will be how would they evade or outturn the immune system? Why is it that our immune system, which is so good and we trust it to such an extent and it has got such an important aspect of defense system, why does our immune system fail us? And how can we overturn that? So that's going to be the basis of whatever we discuss. Now, also you have to keep in mind the most common cancers in USA, for example, if you were to compare male and female, again, a repeat slide from your pathophysiology, and skin, lungs, intestine, kidney, and then genitourinary is a little bit different between male and female, but pretty much all those organs, they are aligned by epithelia, endothelia, or dividing, are vulnerable to that. But it could be anywhere. But these are one of the commonest tissues that we have. Now, the concept you have to have is that we already talk about these are cells in our body, like educated T cell, and they are always they're patrolling your body. We call immunosurveillance, and they're looking for anything which is non-self, anything which is bacteria, viruses, so on and so forth. And now, do they pick up the cancer cell? And also keep in mind that the only thing that they are going to look for is an antigen. The only thing they're going to look for is an MSC. The only thing that they are going to look for is an epitope. So they have to follow a protocol in terms of identification. Now, for example, if you see over here epithelium, you can see a epithelium, right? And these are normal cells. All of a sudden, something happens to this epithelium that this epithelium decides to change in terms of cells. So cells change. If you remember, in pathophysiology, we talked about two concepts. I'm not going to repeat it. We talked about metaplasia. We talked about dysplasia. Any cell which is dividing can go wrong. And the problem is that this cell is different than anything else, right? And it's depicted in this case in different color. Now, these cells are surrounding it. Cells of innate immune system will come. If it happens to be, let's say, intestine, we have gamma delta cells over here, but all these cells come over here to identify. And of course, they will identify this cell as non-self, provided the cell present their antigens. Okay? Now, what happened is that since the tumor cells basically are not the normal cells, so they are different cells, right? Now, if the tumor cells, they present a different antigen or a variation, right? So many cells will be knocked out because they have no way for identification. They will leave them alone. There's nothing for me to identify. Right? So one of the strategies for evading immune system is that these cancer cells will decide not to give their ID at all. So these cells will be helpless, and they would in a way be resistant to killing, because again, NK cell still has to look for something. And as you can see from this slide, that the more heterogeneity, the more variation in the cell type we have, the more are the chances that our immune cells will be unable to identify them, right? If it's that's why the difference between a benign cancer and a malignant cancer is, because you remember the graph I showed it to you, benign will still have the same cell type as compared to malignant, which have more variability and more heterogeneity, right? So it's difficult for us to kill them. So you can see from here, as the variation increases, so do the cell's immune system will run away to such an extent that these cells are then dividing on their own and they are uncontrolled. So they bypass the immune system. There's nothing immune system can do, right? And they spread, we call it unchallenged. One of the cells that is there to regulate the immune response, right? And this is a cell that's going to, remember I gave you the example of the guy who has hold that stick or in orchestra, he's moving those sticks. People kind of understand. I don't understand what he does, but people playing, they probably understand when to start, when to begin, what to do. So in immune system, that person, the head of that orchestra is a Treg, regulatory T cell. He kind of sets the tone, Th1, Th2, Th17. So you kind of go around to kind of mount a harmonious, melodious, or whatever you want to see, a very well orchestrated immune response. So the problem for many cancer is that the cancers recruit that particular Treg to their side, to their advantage. So this Treg over here, you can see from here, is recruited by the cancer cell to act on their behalf and even say, everything is okay, don't worry, I'm going to take care of it. So Treg is a major concern that we have. We have to do something with the Treg, and we have to understand why all of a sudden a cell, which is the key player, it works opposite and works contrary to. So now you start imagining what are the cytokines responsible for Tregs, what do they do, so on and so forth. Okay, let's move on. So the whole idea is that you have to understand that when tumor cells, they divide, so they have to express some components we call antigens, right? And different tumors have different antigens. We call them like tumor antigens, right? Or we can also call them TSTAs, tumor-specific transplantation antigen, because it's more or less the transplantation concept also come because they are being transplanted into our tissues. Okay, and they are present on many tumors in a variety of animal species, including humans. So that's a good news for us, because if tumor antigens are present, so this would mean that still our immune system can do something if it wants to do something, number one. Number two is that if these tumor antigens are there, antibodies can be formed against them. Number three is that these tumor antigens can be floating in the blood or tissues, so we can take them and identify as a diagnostic test that there's something going on we need to fix. Okay, but by and large, the fight between the immune system and the cancer is, and that's what I said, most of the time cancer wins. If you were to look at the foundation of that, our immune system, whether it be an innate or adaptive, fails to destroy cancer cell. That's by the end of the day. So you can imagine what type of cancer therapy do we need. So you firstly need to make sure that your immune system can identify that. You want to help immune system, because immune system is there on surveillance at all time. Even now, none of us hopefully is on anti-cancer drug. But all of our immune surveillance is going on because of the possibility, because we do have cells which are dividing. If that is jeopardized or fails, then we are vulnerable at any time. Okay? So the question you may ask is that where are these antigens coming from, and how does our body take care of that antigen, right? Now, you also have to keep in mind that the cells are dividing, okay? And many things can happen in a dividing cell, right? That's why even for antibody, you had RAGs 1, RAG 2, recombination activation gene controls. So all those enzymes are there. Something happens somewhere in the line of assembly for the proteins or genes, what we call mutation. So something bad happened, the cells are mutated, okay? And also keep in mind a little bit of genetics, that there are some genes there which are oncogenic. So they have potential to cause cancer. And there are genes over there that will be anti-that. So it's always kind of a balance that we have, like we talked about when we talked of apoptosis. I told you about pro-apoptosis and anti-apoptosis. Okay, so likewise for cancer as well, we may have two mechanisms working at the same time. Okay, one promoting it, one inhibiting it. Okay, and if there is any problem in that, right? That's why if a person has radiation. So radiation actually go and mutate your genes. That's why if you're exposed to too much radiation, all those people in Hiroshima and Nagasaki, even for generations, had cancers. This was not the problem that people got killed, but people in their progeny had mutation of their genes because of high radiation. So high radiation per se is carcinogenic, because it messes up the system. And then the wrong group of cells, we call clones, they amplify. We call that clonal amplification that happens. Okay. Now, again, keep in mind that whether it be a tumor antigen or any antigen, they pretty much follow the same rule, right? In terms of being an antigen, again, the same size for the MSC class 1, same size for MSC class 2. But the important thing is that these antigens, which are immunogenic, have the potential to induce immune response. So they have potential because they are antigens, right? The problem will be, for some reason, if there are non-immunogenic tumors, which basically will act. Okay, so it's going to be self-antigen, and by design, our bodies should not react to self-antigen, isn't it? So there would be another strategy that many tumors will do, that just camouflage. So they go into you and put on the external coat of your normal cells like MSC class 1, 2, and your immune cell will come and say, hey, it's just like what called identity theft. So you have identity theft, so they do that. Right? So these are some of the things that we are fighting in terms of drugs that we normally use. So if that happens, it will be tolerance, because our system will still go and look at the external surface area expression of those antigen. If it sees self, good, no problem. Now, if you look at your book, there are many different types of tumor antigens that we are aware of today, leading to different cancers. So you can see over here, these are the categories, these are the type of the antigen, this actually is the name of the antigen, and these are the type of cancer that they get. What I want you to do is that if you pay attention, surprisingly, some of the tumor antigens are coming from normal cellular gene products. So your normal gene products are there, is normal, right? As compared to, these ones are no, as compared to mutant gene products, right? So if you see, you can, it makes sense that if they are mutant, they will cause problems. But again, normal can also cause a problem. So what happened is, one of the normal is, for example, embryonic, we call them fetal antigens. They were there in the fetal life, they persist. Okay. And sometimes when the cell differentiate, like you have a B cell having 5 steps to differentiate into the normal B cell, pre, post, all these different type of cell. So you go for differentiation step. Again, they all are controlled by the genes. If something goes wrong with there, you may end up with a problem. Okay? And then finally, what may happen is that you have a order to a cell to amplify a particular group of cells. For example, the other day I was telling you the hyper IgM syndrome. And the reason was because if there is no class switching, so your body is producing more IgM than is required, right? Now, this is a normal process. The overproduction of IgM, which is a big molecule, is going to jeopardize the whole system. It's going to mess around. It's not good for you. Anything which is not required is not good for you. So too much of IgM will cause a problem. So you may have some of the clonal amplification for some of the cases. Like, for example, all of a sudden, you got allergy, right? So you need a T cell to go and proliferate. So if this proliferation goes out of control, if they were to make 1 million T cells, they start making 1 trillion. So those extra one are cancerous now. So they will go a cancer we call lymphoma. So you can see at least 2 lymphomas over here. They can also cause breast and ovary cancer. And also so you can see most of the cancer that we see today, blood cancer, breast, melanoma, lung, even other are coming from your normal gene products. Okay. Whereas when you have a does anybody remember when I taught pathophysiology, I said about a guardian gene? What was that? Very good, P53. So P53 was a guardian gene at that time. And it said if their levels are up and down, then we are a problem because that was a regulator. So in this case, you can see that if there is a mutation for that, a mutation for example, a P53, right? Or you have some other proteins which are messed up, you may get different type of cancers. You get different type of cancer. So this used to make sense to us. We know we are still working on how people get cancer and how to cure. Till later time, we also found out that it's not only the mutations in your genes, they cause cancer, but sometimes the viruses also transform your gene. So that's another issue. So what will happen is, this will suggest to you that viral infection can cause cancer. 30 years ago, nobody would believe that. And then some careful studies were done. I think I did mention about that when I was teaching pathophysiology, about some of the physicians, probably it was in Germany, they picked up samples, biopsy samples of women dying of cervical cancer. And then they found out all of them had HPV, human papillomavirus. So they did a very careful, and then that led people to believe that virus can cause cervical cancer. That's why it's now mandatory Gardasil for, I used to say 5 years ago for girls only. Now they say for both boys and girls. So that again will tell you that the viruses have an ability to transform a gene and cause something like cervical cancer, right? It's not only HPV alone. That's why we say oncogenic viruses. We'll teach that in virology. Oncogenic viruses, some viruses that have a potential to cause cancer. Epstein-Barr virus is there, and HPV, of course, is on the top of that. Okay, now let's give you a little bit of detail about what normal gene product can cause cancer. Embryonic melanoma-associated antigen, embryonic antigen CEA, that's where they test for prostate cancer at all times. Men over 40. Alpha-fetoprotein, these are embryonic. If you look for deviation of HER2, right? Because the same cell differentiated, and then again, for clonal amplification, I just give an example, overproduction of a particular cell like lymphoma. When we taught mutant cellular gene products, right, we talk of basically point mutations and oncogene products, and some of the antigens come from the somatic mutation. Remember, we got the somatic mutation that normally happens when you have a response. So in this case, what happens is at least a couple of leukemias, chronic myelogenous leukemia, or cyclin-dependent kinase 4 leukemia on people. So these are the major antigens that are involved in terms of a normal cellular gene, which all of a sudden decides to become mutant. And the reason, of course, is because of the genetics. Whenever something is going in production, it can go out of control. I talked about viral gene products. I gave you an example for human papilloma virus. You know, what's the incidence epidemiology of current epidemiology of people having HPV in this country? Google. You're working at Google. Yeah, it's more than 90. And the interesting thing is that it's not, they used to think that it's an STD. It really isn't a sexual transmission. It is still. They used to think that it's for those people who have more than one sexual partner. They used to think many things, but everything is being challenged and everything is being changed now. You know, they used to think that we used to give Gardasil to sexually active girls, and they used to give an age like 12 years. And when CDC was reported 10 years becoming pregnant, they would even decrease the age to 9 years. And then also they would say, okay, it doesn't really matter whether they are sexually active or not, you still need to give it as protection. So you can imagine that's the importance of epidemiology. It's statistical based thing. So everything has to be based upon statistics.
But there's different types.
Different what?
There's different types of epidemiology on each one type. So
Oh.
there's HPV 6 and 11, which is
Yeah, don't worry about that. Don't worry about that. Right now, what we are trying to say is that there are 26 types of HPV. I'm not going to bombard you with 26 right in this, but what you need to know is that human papilloma viruses have a potential to cause cancer. That's what I want to try to emphasize you. That's what we call, because they transform your gene. That's what you need to know. Okay. The other important thing is that some of the tumor antigens are encoded by oncogenes, right? So the most notorious example for any tumor antigens which are encoded by oncogenes are retroviral oncogene. Does anyone know the example? Any example for retroviral oncogene? No. AIDS, correct. AIDS is a retrovirus. AIDS. That's why many a time people of AIDS would have cancer. Does anybody know what's the name of the cancer they get? Okay, Kaposi sarcoma we'll discuss later. But the important thing is that the mechanism of action of oncogenes are that they cause chromosomal translocation, point mutation, and gene amplification. So these are some of the proto-oncogenes. So we call them proto-oncogenes. These are those, that's what, the case of that person we discussed earlier, some of the celebrities, they want to go and check up their potential for that particular gene if they have the potential or probability to cause infection. That's where it is coming from in terms of factor. But by the end of the day, what you need to know is that your immune surveillance is compromised, right? And also keep in mind, like AIDS, it's not only virus, it's also immune deficiency as well. So your immune system is deficient to mount a response, right? So many immune deficiency, whether they be primary or secondary, will compromise the ability of immune surveillance. Like, for example, if you have a primary immune deficiency, which is congenital, you may have hepatocellular carcinoma, right? And you can see these are the associated viruses. Now, these viruses go into another direction. They are hepatitis B virus, Epstein-Barr virus, human papilloma virus, but you can see that they basically are going towards immune deficiency. So they make your immune system deficient, and then you become vulnerable to cancer because your immune system is unable to mount a response. That would tell you that all of us want to have a potent and patent immune system to fight against cancer at all times. Okay. And then the other thing is that what does the tumor do? Why the tumor causes problem? What is the mechanism that tumor, employ in terms of, giving us a problem? Because we can use the same against the tumor. So once we know what does this tumor carry in terms of ammunition, in terms of, the weapons it has, so we can have an antidote for that. Okay. Now, in this case, you can see from here, a lot of that studies are still unclear. Even after so many years, we are trying our best. And like, for example, we know that there's a role of antibodies and B cells and complement, right? But we still don't know. It's poorly understood. We know that T cells are employed, but again, we are still struggling for that, right? So all our players for a normal immune system, whether it be B cell, T cell, LK cell, all these cells which are there is something that you can imagine. The cancer, it's not like HIV alone, because HIV alone will just put up a fight with CD4 T cells, okay? But the cancer, by far, will put up a fight against each and every component of your immune system. That's why it always wins. And that's why, we are still struggling. And you can see, we know what does the tumor do, but we basically are still finding out exactly why is it, for example, the NK cells would not kill this cell? Why is it that the antigens are not presented, right? Why is it the cytokines are not dealing with it? Because each and every, that's why all these players are important in terms of therapy that we have to have for cancer. Okay. Now this is a good example. Let me see if I can enlarge that. So if you see over here, this is like a tumor cell, right? Or is a normal cell. All of a sudden, a tumor cell comes up and has a tumor antigen, right? Now, the question will be that, for example, in this slide, that what is it that would have caused a normal epithelium to become cancerous? One of the things your book talks about is the levels of the guardian gene P53 or lower. So there is no protective gene. And that can happen because of radiation. That can happen by carcinogens, which are compounds. That can also happen if you have chronic inflammation. That can also happen, you can inherit that in your gene. And that can also happen because of viruses. So we already discussed that. Okay. Now, the cancer tumor antigens are there. Body is going to go and eliminate that. So all the cells of innate and adaptive immunity will come. All the cells you already know, NK cell, and you also already know what are their mechanisms of killing, like perforating, everything is there. And that's what we call cancer immunoediting. So they are going to go, they want to bring back that epithelium to normal, and they may be successful. In this case, there's a best scenario you can see from here, protection. But if they fail, there are two examples. For example, in this case, you can see it's a equilibrium, like a fight being put up by immune system. Again, you may see a little bit of changes, but you still have not won the war. You may have delayed cancer or may have less severe cancer or so on and so forth. But how does the immune system, in this case, fails? And that's what we are doing, is that all those markers which are expressed, remember that each one of the cells that we have, whether it be a CD8 cell, whether it be a CD4 cell, an NK cell, we already know what's the mechanism of killing. So cancer cell will block that. It will secrete something to block it. You need MSC to present is going to downregulate MSC expression. You need IL-2 for secretion is going to down. So you can see this is how cancers work. Look, the question you have to ask yourself is, how could they do that? So they probably have mechanism. That's what we are making all this effort in terms of understanding what are those mechanisms. Okay, and I'm going to touch base on that. Again, you can see from here, macrophage is an important player. And these are actual those receptors that we've been talking about, complement receptors and some of the MSC class 2 and class 1 receptors that macrophage express. And these are 3 melanoma cells, so they will bind with that. So that's an actual real binding, right? And this melanoma cell will try not to engage with macrophage, so it's going to kind of inhibit that. But we have to activate the macrophage to go and chew that up. So it's going to digest them and kill them. Okay, we already talked about that. Now, it goes without saying, one thing I just want to make clear, in this lesson, I'm just going to give an overview, very, very global overview. I'm not going to go in detail. So you just have to be a little bit of kind of speculative in terms of thinking what can go wrong. So we know the cytokines are important, okay? And I also told you that one of the cells that is very important as a key player is a T regulatory cell, okay? Does anybody remember what is the most important cytokine that the T regulatory cells secrete and they kind of take effect from? Sorry? So say it louder, you're right. Yeah, TGF-beta. TGF-beta. TGF-beta was their main. And what does TGF-beta stand for? Tumor growth factor. Now you know that even a cytokine has a tumor growth factor. And you wonder, oh my goodness, I thought this is there for my health. And this particular cytokine is a cell secreting cytokine, which is going to allow tumor to grow, which is a fact. But we need it. We just call it TGF-beta because that's what we found at the time, TGF-beta. And we need it. You know that in Th1, Th2 things we need it. So the reason is because when those tumor cells produce TGF-beta, it promotes their angiogenic or immunosuppressive properties. They use that. That's why they want to imply TGF-beta on their side, because TGF-beta will come to them and T regulatory cell will say all clear. So all the cells will go away. So who's going to benefit from there? Cancer. So we still are struggling to find out why does it do it? It's more than likely that it's doing for us, but we are still struggling to find why is it doing it, okay? And then there are many other cytokines that we are using. For example, if you remember when I say the TNF-alpha, what does TNF stand for? Tumor necrosis factor. Again, all cancer cytokines. So you can imagine all these cytokines that we usually think, which is the Th1 type cytokines, basically are discovered while we were working on cancer, right? TNF. So we need TNF-alpha, we need gamma interferon because we want to upregulate MSC class 1, right? So this means some of the tumor cells who want to evade identification will try to bring the MSC1 and MSC2 down, okay? But we want to increase that, okay? So we've been using all these vaccine as trials. You can see clinical tumor vaccines, but I'm just giving you, a sad story that we used to think cytokines are magic bullets. The problem with the cytokines is, if you remember the chapter of cytokines, you need them in very small quantities, and you don't know the precise balance. You never know at what level they're going to do good for you and what level they're going to be bad for you. So we're still kind of struggling with that, but we try them. So these are the limitations that we have because there are some factors which are tumor-related and some host-related factor, because it's like hypersensitivity, which is designed to help you, but it can overkill, right? So we want a very precise, and we have not, unfortunately, hit the balance. But if you look at the mechanisms that we have in terms of why do tumor escape, and we have list of them. That's where most of the research and most of the drugs are. So let's see what are the tumor escape mechanisms which are related to tumor and related to host. There are two sets, and we are working with drugs on both sides. Okay. Number one, failure of tumor to provide a suitable antigenic target. So, as I said, our cells need ID. It doesn't provide, and this is what it will do. It's not gonna allow MSC class 1 or other things to be expressed on the surface. Nothing can do. Failure of tumor to induce an effective immune response, like lack of antigenic epitope, decreased MSC, lack of co-stimulatory signal. Remember, I told you that these need to have a co-stimulatory signal. The tumors will block that. So whatever they do, we learn from them and put up a fight with that. If you want to go to block CTLA4, we will reverse it. You want to go and block CD28, so they play with it, and we also play with that. That's where the drugs are coming up. Okay, so you can see each and everything that we need in terms of a normal response of what you have learned so far. As I said at that time, you just have to ask what if everything can be blocked by the tumor. When it comes to host, we also have a problem, because the thing is this, that there could be immune suppression or deficiency of the host. And even if you want to, because remember, we have to have that system to kill infections. You cannot, it's just like argument that the police should not carry guns, and how they're going to then do their job, right? It's just like the cells in the body, they carry all these ammunitions, right? So we cannot disarm them. If you do disarm them, then you may save yourself from cancer, but you may be prone to infection. So that's a continuous kind of ongoing predicament that we go through. And then again, for tumor as well, it also depends upon the site. Some of the sites are so rich in terms of blood supply or lymphatic drainage, the tumor will utilize it and spread out. Because one of the other things the body would do will try to contain the tumor, like infection. Because for the body to fight a cancer or fight a transplanted organ or fight a bacteria, virus is pretty much the same, because it still treats them as non-self. That is the basis of the put-up fight that the body does. Okay? So now, these are some other mechanisms that you can see where the tumor avoid immune recognition. We already discussed low immunogenicity. If the tumor don't present, like for the tumor cell, it doesn't express any antigen. So what is it that cells will come bind? There's nothing to bind. So let it go. The other thing is the tumor treated as self-antigen. So its tumor cell will come and put up a camouflage. Hey, I'm one of you. So there's nothing you can do about that. If they come and modulate the antigen, they kind of come and present those antigen, which basically, they don't really show their guns. They kind of show them, false, ID. We are your friends. Immune system will just accept it. That's another problem that we have. So they can come and fool around and change the antigen modulation. Okay. And what they also do is that, for example, they know that steroids and they know that tumor growth factor inhibitors are required. They already have this knowledge of what is it that's going to inhibit immune system. So they will come and spread it. So there's nothing you can do. For example, remember I told you the CD28 needs to talk to B7B molecule for activation. And I also told you when activation has to be controlled, now the B cell will disengage CD28 and hook on CTLA4, CTLA4 to stop it. So the cancer will come, instead of allowing CD28 to hook on, they will immediately put the brakes on by CTLA4. So there's no activation. So they're pretty much clever. And then again, you may have a tumor at a privileged site. Like, for example, you talked about the immune spirit site where there's no, blood supply, no lymphatic site. But anyway, so we also use all those antigens for immunodiagnosis. We do that. We also looked at the prediction of immunological cross-reactivity, because if these antigens are secreting those proteins, so whatever antigen markers are there, they're in blood, right? Or they're in the tissues. We can have blood tests. That's what we normally do as like you have a pap smear. So what are they testing for? They're testing for the changes over there in terms of metaplasia, hyperplasia. If you look at CEA, alpha-beta protein, so these are tests used as diagnostic, because the moment they start appearing in the blood, this means that something is cooking up. So you can kind of go and work. So we use all these proteins and antigens as diagnostic tests. Okay, and there are tons of them. Very specific for antigen, for cancer of ovary, and then we also go and look for the monoclonal antibodies as well, because some of the cancers, for example, if there's a cancer in the brain and we know what kind of antigen is going to represent, so we give a tag antibody, it goes and lodges in the brain, and then we can detect it. So that's for detecting purposes as well. Same technology that we talk of an antigen-antibody reaction. Okay. The other question is, as a discusser, can we do immunoprophylaxis? Yes, we can. I'll give you an example for HPV, right? That can hopefully prevent cervical cancer in women. We are still working up if there is a immunization focused on oncogenic viruses. HPV still under discussion, debate, we don't know. And most of the time what we are doing is that we are, for ethical reasons, we do all these experiments on birds and animals and so on and so forth. And then the question you have to ask yourself, can that data be transferable or, transposed to humans? The data is insufficient, so we don't want to try. That's why many times you hear on news, they are looking for people who are willing to kind of be a part of that survey. As far as immunotherapy is concerned, I already told you that what we are doing is that once we figure out what is the problem, like you can see from here, we already know that this is a tumor cell, right? And and all these cells which are there are going to come over here and help us. Dendritic cells are looking to take up one of the antigen and process it. The antibodies, the specific antibodies again will come, because all of these are mobilized. They want to come and look to kill, right? So if you want, the drugs that we are developing is, once we figure out what is it that is missing for immune response, we have to give that drug. Like, for example, if you need T cells, we need to give T cell. If you need B cell, we need to give B cell. If you need cytokines, we need to give cytokines. To such an extent that sometimes we take this, we call LAT, you take your lymphocytes out and kind of equip them and stimulate them to express those particular attachments they can hook on to cancer cells in your body. We call lymphokine-activated killer cells. So these are some of the treatments that we have these days. Okay, and then again, I just picked up one of the slides from your DiPiro book, probably it's a DiPiro. Yeah. So you can see from here, all the way from an APC talking to a T cell, CD4 T cell, even on CDR, all these steps that we have where cancer is going to stop that. So we have the drugs. So we have like hundreds of drugs on each and every aspect, whether it be receptors, acting on the receptors, whether it be acting on the signaling pathway, like we talked about the calcium, whether it's acting upon the IL-2 receptor, whether it's acting upon the transcription factor, whether it's acting upon the antimetabolites, and you can see tons of drugs, anti-cancer drugs, all targeting the immune response right from the receptor to the inner cell. So these are all there in the market, and they are available. And one or more, two slides. This is actually coming from, I don't know whether you've heard of one of the big gene tech companies. Some of the private companies are where they make the drugs. And they basically are working on different type of cells to make sure that they can fix the deficit. So you can see if there's a problem with the recognition of antigen, they have drugs over there. If it's a problem of MSC, they're going to present over there. If it's a problem of any of the signaling pathways, so you can each and every step, all the way from antigen recognition, presentation, signaling, so you have sets of anti-cancer drug, which is considered as an immunotherapy, and they are all available in the market. One other vaccine is still in the market for cancer. I just picked up from the latest Nature edition. So what they are doing is that they still think that since dendritic cell is the major cell, so they would take dendritic cell, right, and make sure that whatever is missing in the immune system, they want to insert it into dendritic cell. We call it the dendritic cell vaccines. So these are developing to fight cancer once we know what type of cancer the person has and what is it lagging, if it's lacking, because we have this ability to insert those receptors, upregulate, downregulate. So we kind of take these cells out of your body, dendritic cell, and kind of educate them and prepare them and arm them for a potential target, which in this case happens to be a cancer cell. Okay? All right, thank you. And are there any